Welcome again. In the second part of presentation, I will try to demonstrate our live in a box case, which performed cardiopulmonary ablation. In this case, before the procedure, we checked the basal heart rate of the case, and in ECG, his rest heart rate was nearly 60 bpm, and then we administered 2 milligram atropine to demonstrate the atropine response, and after atropine administration, heart rate increased from 60 to 110 15. So in this patient, after procedure, we will try to achieve this heart rate response to confirm complete vagal denervation. As you see that before sheath inserting, in this case heart rate was 64 bpm. Actually, in some vasovagal syncope cases, you can see significant asystole or significant hypertension due to reflex phenomenon and due to pain. But in this case, we didn't see any asystole or something like that during sheath insertion. We usually insert 3 femoral venous sheaths, one of for coronary sinus catheter, the other one is for right ventricular backup pacing catheter. We also see this catheter to demonstrate His potentials, to check whether there is any prolongation on AH and HV intervals, and the last one is for mapping and ablation catheter. Yes. After inserting sheaths, we usually try to get anatomical mapping of right atrial structures like superior vena cava, right atrium, and inferior vena cava by using coronary sinus catheter. During this time, you will not to know activation or voltage mapping of right atrial structures. This mapping just for to check close relationship between right and left atrial structures during procedure. In Turkey, we cannot use ICE catheter, so we usually perform transseptal puncture by using fluoroscopy guidance. And after transseptal puncture, we exchange our SL1 catheter with an Agilis catheter because it will facilitate your mapping and contact during ablation. And then we usually try to get voltage and activation mapping of left atrium by using an Optima catheter. It's the easy way of left atrial mapping. We will just get a quick left atrial mapping with this method. After completing of left atrial mapping, we will exchange Optima catheter with RF catheter, and then we will check again whether there is any untouched tissue with Optima catheter. Yes, we are going on the mapping with RF ablation catheter. Yes, I think we completed the left atrial mapping too. Now, we usually start from left inferior GP during cardiopulmonary ablation procedure. We will try to demonstrate whether there is any fragmented electrograms in that mitral isthmus site. We try to contact all around the mitral isthmus area. Yes, here we go. You can see fragmented potentials in that site, but before mapping in that site, you should take care that if your catheter cause any perimeter atrial contractions, you can see fragmented like potentials in that file. Yes, please look at that. Please look at that. This site just demonstrate fragmentation due to perimeter atrial contraction, because activation wave of coronary sinus is changing at this time. Please check again. Yes, you can see that. So this site is not a real fragmented potential. Please look at here that you can see the real activation wave of coronary sinus. So this site is not a real fragmented potentials. So we will not perform ablation in that site. Again, we are checking all the area. In this case, we didn't find any fragmented potentials in mitral isthmus area, so we didn't perform ablation in that site. Now we go to the left superior GP. Yes, here we go. You can see fragmented potentials here. We are in we are in roof area between left superior pulmonary vein and left atrial appendage, and we started ablation. We usually perform ablation with 35 watt in roof area as a starting power. Now, as a typical response, you can see significant asystole or AV block during RF application in both left inferior and left superior GP sites. Now we are in left superior GP. We're performing ablation. Yes, a sinus bradycardia and then asystole. It's a typical response for left superior GP during RF application. Yes, you can see that 2.3 second asystole was seen during RF application. Again, we are still in same area. We are performing ablation. Again, significant bradycardia and asystole, and also you can see AV block in the same site. And we are performing backup pacing. We should not administer any atropine during procedure because it will change your strategy completely. Because we will try to complete the, we will try to define our target by using atropine response. Another vagal response during RF application is seen. Yes, bradycardia, AV block, yes. Yes, again, bradycardia and AV block. After we completing our ablation in that site, you will not see any additional vagal response in the same area, and it will demonstrate that you completely eliminated those GP sites after RF application. And then we go to the next station. We are in ganglion A site. As I mentioned before, it's between superior vena cava and high part of right superior pulmonary vein. Now, at this time, heart rate is a little bit decreased and between 50 to 65 BPM. before ablation on ganglion A site. Actually, you can see that these tissues, these GP sites is usually epicardial structures, and between superior vena cava and right superior GP. But in the first part of RF ablation, we try to get a little bit more antral site to not to cause any ostial stenosis. So actually ostial part of right superior pulmonary vein demonstrate a better contact with superior vena cava, but again we will start ablation from more antral side to not to cause, yes, you can see that, not to cause ostial stenosis. And we started ablation. You can see the fragmented potentials. Usually we can see low amplitude fragmented potentials in that site. You can also follow electrogram properties during RF application. It's not a problem. Yes, you can see low amplitude fragmented electrograms. Now, high amplitude fragmented electrograms in the near side. We try to completely eliminate. Yes. If you look at here, heart rate is now 70 to 75 BPM after a couple of lesions on ganglion A sites. A little bit increase. We are still performing ablation. You can see fragmented potentials along the ablation line. Our ablation endpoint is complete elimination of those fragmented electrograms. Again, you can see fragmented electrograms in the same area. Actually, there is no fibrosis in those sites, just fragmented potentials. You can see the heart rate here. Now we are in ganglion B site. We pulled our catheter a little bit below. You can see that we are still close to right atrium. It's very important because GPs are in those sites. Yes, you can see the contact point of RF catheter and also see fragmented electrograms in here. Again, we are in ganglion B sites now. We are continuing ablation. You can see fragmented potentials all those sites. It's very important because this point is very important because heart rate is 75 or 78 BPM after ablation on anterior right GP and ganglion B sites, and we still far from our target heart rate. So we will a little bit close to ostium of right superior pulmonary vein to check fragmented potentials because we couldn't achieve our target. You can see both fragmented potentials and pulmonary vein potentials in dead sites. Yes, you can see that. Both pulmonary vein potentials and fragmented potentials. Heart rate was 75 BPM before ablation in that site. Here we go. You can see that heart rate increased 95 BPM after just 2 or 3 ablation lesions. It's very important. And if you remember that this site is very close to superior vena cava. We are very close now, superior vena cava. In that site, we were a little bit far from the superior vena cava. We completely eliminated electrograms. You can follow up. Yes, please look at that. Heart rate nearly 100 BPM now. You can see that. We try complete eliminate all potentials. You can see here no electrograms after ablation. It's very easy to define those fragmented electrograms in anterior wall of the right superior pulmonary vein. But you should check relationship between superior vena cava during ablation procedure. You should be close. Then we completed our ablation in anterior right GP side, so we now go to the posterior right GP side again, and we will check fragmented electrograms in that side. You can see highly fragmented electrograms, high amplitude fragmented electrograms in proximal electrode, and it will demonstrate the next target. You can check your way by using proximal electrode of ablation catheter. You can easily see those fragmented electrograms alongside intraarterial septum. Yes, now we are close to ganglion C site, just opposite side of coronary sinus wall. We usually don't see any significant increase on heart rate during RF application on those sites because, as I mentioned before, ganglion C mainly provides vagal innervation of atrioventricular node, but we perform ablation in that site just for complete vagal denervation. You can see fragmented electrograms here. Again, we try to completely eliminate all those electrograms. Yes. Try to get good tissue contact during RF application. You can see the catheter stability. We don't use general anesthesia in this case. But if you use general anesthesia, it will be better. It will be better for catheter tissue contact stability. Of course. Now we are very close to our transeptal puncture site. Very close. can see ablation line. Yes, we completed our ablation in left atrium side. Heart rate seems in 98 or 99 BPM after completing of left atrial ablation set. It seems very stable at this level. Please look at here. Our ablation lesions is just opposite side of superior vena cava and interatrial septum. Yes, you can see that heart rate is still stable around 99 BPM level. Now you can see ablation lesion set. It's a typical lesion set for cardiopulmonary ablation. Maybe we can think that whether we stop the procedure at this level because heart rate increased from 60 BPM to 100 BPM, but in this case we check the atropine response before the procedure, and after atropine administration heart rate increased to 115 BPM, so we try to achieve this target. Now we just checking whether there is any significant scar tissue in superior vena cava, but this patient is very young, so we didn't think any significant scar tissue before ablation, but just try to demonstrate it. And now we will just perform ablation in opposite side of left atrial lesions in here from superior vena cava area. Usually you will not see any fragmented potentials in higher part of superior vena cava. Actually you will not see any electrograms in that site. So we usually don't perform ablation in very higher level of superior vena cava, and here we can see fragmented potentials in opposite side of left atrial lesion. So we started ablation. This is the first ablation point. Please look at heart rate now 110 BPM after just 2 additional lesions, one of here, one of here. Amazing. We try to get in touch with left atrial lesions. Yes, you can see the catheter contact. After catheter stability, again we are starting ablation. Again we will try to completely eliminate all those potentials, but heart rate is stable and nearly 110 BPM level. In right atrial side, we usually don't perform ablation in interatrial septum area because to achieve good catheter tissue contact is not easy in right atrial side, and also your catheter may move his area or atrioventricular node area in right atrial chamber. So to perform ablation in left atrial side of interatrial septum seems more reasonable or more reliable in those cases. Yes, you can see fragmented electrograms. We are nearly ganglion B side, a little bit higher of ganglion B sides, between ganglion A and ganglion B sides. You can easily see the fragmented potentials. There is no change in heart rate. It's still 110 BPM level. We are pulling back the RF catheter. We are checking fragmented electrograms and our lesion set. Yes, you can easily see that both lesions are very close. Yes. Please look at here. Also here you can see the fragmented potentials in that sides. As an important point, you can also see fragmented potentials in sinus node area, because as you know that axonal fibers of parasympathetic neurons may cause this fragmented potentials in sinus node area, but you should not perform ablation in those sites. So checking contact between left and right atrial structure is very important to target to select your true ablation area. Yes. Now we pull our ablation catheter to inferior vena cava level. We finished our ablation procedure. Heart rate is 110 or 110 12 BPM after ablation. Now we will wait 10 minutes and check whether there is any decrease on heart rate. A little bit quick. We are still waiting, and then we will administer 1 milligram atropine. Heart rate is 110 BPM. Yes. Now atropine was administered. The first atropine bolus, and we will check the heart rate and atropine response. If heart rate increases more than 20%, it's demonstrated your cardio ablation may not be effective. But there is no consensus for the level of atropine response. Yes. As you see that there is no significant increase on heart rate after first atropine administration. Heart rate still is 114 BPM level. We are still waiting. I'm talking blah blah blah. Yes. Heart rate is increased only 2 BPM after first atropine administration. And a little bit fast. Again, yes. This is the second atropine bolus. Heart rate was 112 BPM. We are waiting. Heart rate is still 112 BPM level. Yes, there is no any additional increase on heart rate. It seems stable, and the procedure finished. Thanks for your attention.